So continuing our saga of tumors which are histologically benign, but they behave in a malignant manner. I started off with chiasmal gliomas, low grade in pathology, but can be a killer. Then we discussed yesterday about craniopharyngiomas, again supposedly benign, but all of us know how devastating they can be, especially recurrent ones. Same way we discussed about sphenoorbital meningiomas. Now, if you look at it biologically, histologically, they are benign, but we all know they have such a terrible course. So this is a classical, but have the pointer. Yeah. So this is the classical way, the old traditional way in which sphenoid wing meningiomas were described or classified: the medial half, the middle, and the lateral one. But sphenoorbital are a little different from them. So I personally look at them as five. They have five components. The dural component, of course, all meningiomas have a dural or arachnoid capsules from which they arise from. They have an orbital component, which extends into the orbit. They have an intradural component, which may extend inside the brain. They have an extradural component, which sometimes goes infratemporal also. And they have a soft tissue component, involves again the orbit, the external to the periorbita, and sometimes infiltrates into the muscles of the orbit. So essentially, I see them as five components. So you're not just dealing with the dura and its intradural component as we do for other meningiomas. So we need to tackle. And the sixth one, which I kept hidden, the bony component as well, which I'll just be highlighting later. So this is the dural component. So what we see here, it's this not the, it's an unusual. Most of them have an end plaque variant. So they extend far beyond. It's just not the dural tail, which we see in a classical meningioma, but you would see that much beyond the primary location of the tumor, the dura will enhance, and that will be a component of the dura. So that involves that your craniotomy needs to be much, much bigger than we plan. Second is the intradural component. Of course, this is common for all meningiomas. You know that about how it's seen in sphenoid meningiomas. You can have a orbital component, which can involve both the orbital muscles as a soft tissue in the orbit, and you have an extradural component which can go into the extradural or infratemporal plane, also into the zygoma and the subzygomatic plane as well. But what is interesting is the bony component. So this is what classically we think is hyperostosis along associated with the meningioma, which is common with other meningiomas as well. But in sphenoid wing meningiomas, it has been proven through multiple studies, especially PET scan studies, that this bony component also has tumor infiltrates. So your excision is incomplete unless you take out this bone as well. So you need to be more radical with the bone in a sphenoorbital meningioma, unlike the hyperostotic component of other meningiomas in other locations. So in fact, there is a grading also for this osseous component, which is essentially it is graded as 3. If it involves the lesser wing, it is 1. If it involves the greater, it is 2. And if it involves the body of the sphenoid, 3. So there is a separates the bony hyperostosis, which we see along with sphenoid orbital meningioma, is the tumor. It's not the dura and the soft tissue part alone. So we need to be radical about that. Now, answering Professor Kate's question, I must confess that my series, this is some of the large published series about sphenoorbital meningiomas. You have one at the top with this 130. Our series is not mine. Mine is a very modest series of 17 cases in the last 7 years. And this was published 3 years back. So maybe another 3 cases after that. But this is our results. You would see proptosis is the most common. Proptosis and vision are the most common presentations for sphenoorbital meningiomas. And I could achieve improvement in proptosis in only 5 of my 17 patients. Vision also, improvement in vision in only 4 of the 14 patients who had presentation with visual complaints. 10 of my 17 patients had recurrence, and I had to reoperate 3 of them. So these are not very good outcome in terms of meningioma outcome when you talk about other meningiomas in other locations. But this is how sphenoorbital meningiomas are. The important thing is no mortality. All of them are still surviving, albeit with deficits. So that is an important message. They do not, it's not a killer in that sense, but they have persistent vision problem, persistent proptosis, but they generally does not, they do not cause other deficits like other patients. Some of the complications which I like to highlight in my series was epidural hematoma. That is something which I wanted to come. When I talked about having a large craniotomy and taking out large part of the bone, we need to be sure that when we close, we pack that area, because we have a large area, it's a high risk of epidural hematomas, which are encountered in some of the patients. And the other important disabling disturbance which can follow surgery is when you keep drilling the sphenoid, that bone part, you tend to get lost, and you tend to get lost especially in the superior orbital fissure region. And when you tend to lost in that superior orbital fissure region, you tend to damage the nerves which pass through the superior orbital fissure. So you can have disabling. The patient would have presented with visual problem and ptosis. You would give him diplopia. You can damage the fifth nerve. You'll give him trigeminal symptoms. And that is something which we need to be very careful about. And that is the that is the disabling complication, most disabling complication of a sphenoorbital meningioma surgery. Now, how have I evolved? So the sphenoorbital meningiomas like chiasmal gliomas, which I were cranioperitoneums, which I was telling, these are not common tumors. You might get one or two in a year, or two, maximum 3 or 4. So it takes time for one to get expertise over that. So as I said, mine is a modest series of 17. So unless you're in a large institute where you get many cases and you can kind of improve on your techniques. So what are the lessons which I learned about proptosis? So usually I used to be aggressive with the intraorbital component. I used to take out the periorbita, take out all the components within the attached to the muscles, the recti and so forth. And I was to be less aggressive with the orbital walls. And I used to be aggressive with the periorbita. Now, the most important, the best results with proptosis, can't still call it best results, but optimum results with proptosis can be obtained if you're very, very, very liberal with your bony work. You need to take out all the bone in that area. And the periorbita, you need not be very aggressive even in reconstruction. So this is the bony removal in one of my earlier cases. You can see the tumor, the soft tissue part I could take out. I left the bony part. And this is the same in one of my recent cases. You can see the proptosis, the improvement in the proptosis also. So it is the bony decompression which matters. It is, you need to be very, very aggressive with the bone. But as I said, be careful when you reach the superior orbital fissure region. That's where you tend to get lost in that plane, because everywhere it is tumor around. So, but again, the next cosmetic problem which you can cause with your bony removal is if you're be a little conservative with the superior wall, because that is cosmetically disfiguring for the patient. So this is the extent of the kind of bony removal that generally we require for a sphenoorbital meningioma. But I am a little conservative about the superior wall. And the proptosis, again, you see periorbita, it can be a little conservative. And reconstruction of periorbita, although advocated by most of the surgeons who do sphenoorbital meningiomas, I generally tend to close them. You result always the closure is still suboptimal and does not provide the necessary outcome that you wish. As far as visual improvement is regarding visual improvement, again, it is not the soft tissue component. We think that take out the soft tissue component inside the orbit as well as in the middle sphenoid wing region. What is again more important is deroofing the optic canal and the anterior clinoid. So that is in fact the first step of my story. Along with the bony, before we open the dura, as you drill the sphenoid wing, be aggressive and take out the anterior clinoid process also. So take out the anterior clinoid process radically, deroof the optic canal, liberate the optic nerve, and then you tackle the soft tissue component. So that is the most important two lessons which I have learned regarding proptosis and visual complaints, which are the two important, most common presentations of sphenoorbital meningioma. Aggressive bony removal, because it is the bone also contains tumor, and it is the bony encasement which causes visual complications. So, Simpson's grading versus, so this attempt to have a gross total or a Simpson's grading, generally what we talk about grade 0 or grade 1 excision in sphenorbital meningiomas, it is difficult to achieve in sphenorbital meningiomas, and residual lesion is a rule rather than an exception, and the residual lesion is bound to grow. So whatever, however aggressive you are, as I showed, the extent of the dural involvement, the enhancement of the dura, the bony involvement, which may go way beyond what we see on a scan or with the naked eye, however much we do, we can never claim the removal to be gross total. And as I said in my series, I had only 10 out of 17 kind of gross total which we could expect. And what are the predictors for gross total removal? Of course, younger age and favorable histology, like with 1 peak and 6 deletions. And the next question which comes to mind is, what do we do with this residual tumor? As I said, gross total. So do we subject all these tumors for radiotherapy? And as I mentioned, most of these tumors are low grade, grade 1 meningiomas. So grade 1 meningiomas subtotally excised. What is the plan of action for these tumors? Because invariably these tumors tend to grow. So there are two schools of thoughts regarding this. A school which advocates aggressive radiation fractionated IMRT for all residual tumors, especially if it is significant. But I am a little conservative in that. So if a patient has reasonable, so rather than tumor residue, I go with proptosis and visual complaints. So if the patient has a vision has not improved or the vision deteriorates after improving, or if the proptosis persists or worsening, these are my indications for resurgery. And I generally tend to prefer to do resurgery rather than to send them for irradiation because resurgery after radiation often becomes more disabling in terms of cranial nerve palsies. So this is the summary of the algorithm which has been proposed again from the Tel Aviv group. So what I wish to highlight are the three aspects: anterior clinoidectomy, aggressive, a large bony exposure, aggressive bony removal of the base, anterior clinoidectomy before you open the dura, open the periorbital liberally, and reconstruction of the periorbita, although it has been suggested, I am little conservative. So this is the anatomical limits of, when I say aggressive bony removal, there are certain limits. You tend not to go or open up this sinuses because of the risk of CSF leak. And so this is some of the landmarks for your bony removal, and you tend to preserve the TM joint as well, because that can also cause disabling symptoms for the patient post-operative. As far as the soft tissue component, so this is it. So exact all the dura along all these pins, you can take it out. Reconstruction of the dura is a closure of dura is a big problem. You always end up taking fascia lata and using liberal amounts of glue and tissue, but you tend to preserve all the superorbital fissure, the foramen rotundum, and all the foramens here, because you go near them, you tend to cause extra cranial nerve deficits which are not there preoperatively. To summarize, discretion is the better part of valor. Do not chase the tumor aggressively, especially near the canals. Do not attempt for a radical excision. Be liberal, be generous in your bony removal, and less aggressive with tumor which is around the superorbital fissure and the basal foramina, and the tumor involving the cavernous sinus. Maybe the tumor involving the cavernous sinus is we can subject for radiosurgery later on. So this is the take-home message. Surgery should be aimed at symptom relief rather than tumor eradication. Liberal bony removal. These are essentially tumor. The residual tumors grows very seldom, and they do not generally cause disabling deficits like hemiplegia and so forth. It's usually proptosis and visual complaints. And subtotal resection with radiation provides reasonable progression-free survival. That is what literature says, but I said on a personal note, I generally tend to keep them on follow-up rather than subject them to radiation. Thank you so much.